Hi everyone, welcome to researchmd.com. We have, again, my name is Pramil, Cheriyath. I'm a physician practicing in the United States. I'm a program director, internal medicine residency, transitional residency. I teach medical students and residents, and I'm also assistant professor of medicine, two large medical schools. We've been doing a series of morning report cases. So let's start today and see what we have. Okay?
Okay. There's a 68-year-old female.
68-year-old
female presented to the emergency for left lower quadrant abdominal pain.
Say left
lower quadrant abdominal pain that began 5 days ago.
Abdominal pain. Okay, so we got a 68-year-old female, left lower quadrant abdominal pain. So, what's the first thing we have to roll out? We need to roll out an emergency, right? What are the when I talk about emergency, something, what is it called? Surgical abdomen. So, what are the things that could kill the patient right away? Somebody tell me that. What could kill the patient? What are the surgical? Any kind of perforation, right? Perforation or like an abscess can be peritonitis. Okay, what else? What about abdominal aortic aneurysm rupture? That's an emergency, right? Even ischemic colitis, that could be like an emergency. This kind of things you need to kind of act on it like right away. Everybody agree on that? Always kind of think, what is the emergency? Do I need to call a surgeon or not? And then we'll talk about our differential diagnosis, okay? So next thing is like, are we suspecting any of that in this patient? Okay, and then let's go into the differential diagnosis of left lower quadrant abdominal pain. All right, so what are the most common causes of left lower quadrant abdominal pain? I think we can put it into some different categories. Let's talk about the GI causes, okay? So I'll just write here, GI causes. What is the first thing? Most common? Constipation, right? Most people kind of present it like constipation. It's always kind of roll out constipation, okay? Constipation, everybody got that? And then what are the other things we need to talk about? Colitis, okay? What are the colitis? There's two types of colitis. What is called infectious colitis and inflammatory colitis. So we put colitis. Colitis is an infection, and we got inflammation, right? What are the inflammatory conditions?
IBD,
Crohn's disease, ulcerative colitis, and all of those things we need to know, right? So infectious colitis, like what are the main symptoms when you have infectious colitis? You can have diarrhea, right? Of course, colitis, there's inflammation, there's usually have diarrhea, and then you could have like fever, leukocytosis, any other symptom, right? What about inflammatory diarrhea? In those conditions, you can have, of course, you're going to have diarrhea, mainly you can bloody stool. Blood in the stool is very common in that group, okay? Remember that. Everybody got that? So you got like bloody stool, and then you can have, you can also have diarrhea, but fever is like not that much, but of course they can have it. But infectious colitis, like more fever, diarrhea, not much blood in there. Okay? And what are the other GI causes? What about hernia? Any causes of abdominal pain? Okay, tell me some characteristics of hernial pain. What is the patient usually present with? Somebody tell me. If somebody have hernia, like in the groin, what do they usually present with?
dragging pain.
Yeah, dragging type of pain. Okay. And then what else? What are the other things? Sometimes it can be like burning. You can see the gurgling sound in the abdomen also. You have to look. It's more like a localized pain also, right? You can have like a bulge and all that. Now, what are the other things we have to worry about? We need to worry about incarcerated, right? Incarcerated. And what is the other type? What are the other type? Incarcerated what?
And strangulated.
Strangulated. Okay, incarceration versus strangulated. Strangulated. Can somebody tell me the difference between incarcerated hernia and strangulated hernia? What are the difference between incarcerated and strangulated? What is the main difference? Which one blood supply is affected, my friends?
Strangulated.
Strangulated blood supply is affected, okay? Incarcerated blood supply is not much affected, okay? And then, well, the obstruction is going to be in both of them, but the main thing, if I had to remember something, I would say the blood supply, okay? What else is in the abdominal? GI causes, diverticulitis, right?
Yes.
What are the usual symptoms of diverticulitis?
Left lower quadrant pain.
Okay, left lower quadrant pain. They could have like fever, leukocytosis, and all those kind of symptoms. Doesn't have to be diarrhea also in there. Sometimes they might not have diarrhea. Okay, so you have to think about diverticulitis. What type of diverticulitis is going to be in the left side? Somebody. Is it going to be cecal diverticulitis or is it sigmoid diverticulitis?
Sigmoid diverticulitis.
Very good. Sigmoid diverticulitis we need to worry. Okay, so sigmoid diverticulitis. Sigmoid. Okay, cecal is on the, where is the cecal? On the right side diverticulitis. Okay, and then when you talk about, what about diverticulosis? Can it cause abdominal pain? 15 to 20% can cause like dull abdominal pain also. So we can kind of write this also, diverticulosis, okay? Diverticulosis also will just kind of, all right. So we talk about the GI causes. Let's talk about the genitourinary causes of abdominal pain. GU, genitourinary, okay? What is the most common? UTI, right?
Yes.
What are the, you can have left lower quadrant pain also, you can have urinary symptoms, blood in the urine, fever, and all of that. Okay, what about prostatitis in male? That also, what will be the symptoms? You can have fever, abdominal pain, right? Urinary symptoms also common in those kind of people, okay? And what about urethral ethyosis, right? Renal stone, urethral lithiasis. Okay. Depends upon the location of the stone. If the stone is in the lower part of the ureter, right, you can have one of the symptoms. You can have abdominal pain, right? Everybody agree that you can have like flank pain, and then you can have urinary symptoms also, right? Urinary increased frequency, urgency, and all those kind of things. Okay. So that is also very common. And so we talked about that. What about like any other, in the UTI we talked about, okay, let's talk about vascular conditions, right? See, what are the vascular conditions? Somebody tell me the vascular conditions can cause like abdominal pain, left lower quadrant. Ischemic colitis, but like most important, I think, abdominal aortic aneurysm, right? The rupture, right? We have to worry, right? And then ischemic colitis.
Retroperitoneal
Retroperitoneal hemorrhage. Retroperitoneal hemorrhage. Okay. So retroperitoneal hemorrhage, always ask for if the patient is on anticoagulant, right? It's very common. If they're taking anticoagulant, abdominal pain, I always want to make sure there's like a CT scan to rule everything out, okay? So we did the vascular. What are the symptoms? Ischemic colitis, you can have blood in the stool. Previous history of what? Ischemic colitis. Usually, what is the cardiac history? Like atrial fibrillation, previous history of peripheral arterial disease, and all of that is kind of very much important, okay? And then talk about the other most important thing. This is a gynecological issue. This is a female, right? Just say GYN issues, right? What is the most common, like PID, pelvic inflammatory disease we need to know, okay? PID. What are the symptoms in PID? You can have like fever, left lower quadrant pain, then you can have like cervical discharge and all that, right? That's like, those are the things we need to worry about. What are the other things like endometriosis, right? Yeah. Endometriosis. Okay. Endometriosis. What is the classic type of pain in the endometriosis? Usually pain during when? Dysmenorrhea. Okay?
Yeah.
Always remember that. Dysmenorrhea. And what are the other things? Come on.
Ectopic pregnancy.
Huh?
Ectopic pregnancy.
Ectopic pregnancy. Okay. Always make sure you ask the patients periods and all that. What else? What about ovarian?
Ovarian torsion.
Ovarian torsion, right? What is how do you describe the pain in ovarian torsion? Sudden onset, right? Nausea, vomiting, and pain will be like very severe, right? Ovarian torsion is important, okay? What else? Pregnancy, we talk about it, right? Like any kind of ovarian cyst, kind of rupture of the ovarian cyst, right? We can kind of write that ovarian cyst. Or follicular rupture and all that. Okay, and let's look at any other conditions. What about malignancy? Right? Yes. Any kind of malignancy. Let's put in the OBGYN malignancy over here. It's very important also. Okay, and then let's look at some of the infectious causes. Somebody tell me what are the infectious causes? Could be like left lower vein. Psoas abscess can cause it. Right? Any kind of abdominal abscess, psoas abscess is very common. We'll just write abdominal abscess. Psoas abscess. Okay, so we got a huge differential diagnosis. So tell me a little bit more about this case. So what's going on? Like when you talk about abdominal pain, just describe the abdominal pain a little bit for me.
Yes, doctor. Mm-hmm. So the patient had left lower quadrant abdominal pain that began almost 5 days ago. Okay. The pain has been intermittent, but been constant and increasing in intensity for the past 5 days. Sure. And the patient is also complaining of suprapubic pain and dysuria. Okay. The patient states that her pain aggravates after eating. Sometimes. Okay, it's always good to know, like, the relationship with the food and all that, okay? And the urinary symptoms we need to know. What about the bowel movement? Did you ask the history about that? Were they normal? No, I didn't ask.
You did not ask? Because is it important to ask, right?
Yes.
Okay, make sure when you take history of everything kind of, we talk about this huge differential diagnosis, right? Kind of related to the history like that. You need to know urinary symptoms. You need to know the OBGYN history. You need to know like the bowel habits, and also it's very important. Okay, so let's go to the past medical history. What is this? What is the past medical history in this patient?
The patient has hypertension and previous diverticulitis.
Hypertension, diverticulitis. Okay, why is diverticulitis important? This patient said, I had like one diverticulitis before. Does the management change if somebody, let's say if this patient has another diverticulitis right now, maybe one other differential still, right? And then can you have, if you have previous history of diverticulitis, does the management change? Somebody?
No.
Management will not change?
No.
No? Okay. Does it matter at all? Like, let's say it's only like one diverticulitis, right? Let's say you had like two diverticulitis before. Does my management should change?
Yes.
Why is that? Because that's when you have to consider surgical option. Okay, you have to do like surgery in this people. If you don't do surgery, recurrence is very raised. So currently recommendation is like if you have uncomplicated diverticulitis, but you have 3 times, you may want to consider. Okay, the evidence is not very clear, but studies have shown that like a decrease of recurrent diverticulitis is less in that group. Also very important. Okay, family history.
Not significant.
Okay, social history. And what medication the patient is on?
The patient is on losartan and vitamin D.
Okay, all right. And let's talk about the social history. What are the social? Why do we need to know about social history? We need to know about smoking, again, malignancy and all of those kind of related, alcohol use.
Right.
Okay, I don't know, like alcohol use and anything kind of differential diagnosis we can. Okay, what else?
So patient does not smoke.
No,
and occasionally drinks alcohol.
Okay, what about sexual history? Do we need to know about the sexual history? Did you get the sexual history?
No, doctor.
You think you should get the
Yes.
sexual history? It's a crime if you don't do a very thorough history. Okay, next time I'm not going to let you present if you don't take. Doesn't matter, whatever they have, you have to even if it's not abdominal pain, even if it's come with chest pain, I'll make sure I get everything because that's what like a full H&B. I want you to see like a textbook H&B on this patient, right? Remember we talked about it's like all this pelvic inflammation. It's a female, right? Any kind of, all of the sexual history can cause us a lot of trouble, okay? What about psychiatric history? Was it any history of psychiatric disease?
No.
No?
Not significant.
Okay, so no okay, let's talk about the physical examination. Vital signs?
The patient had past surgical history. The patient had inguinal hernia repair.
Inguinal hernia repair?
Yes.
Okay.
And cataract removal.
Inguinal hernia repair. Okay. So we need to worry about recurrence of hernia is kind of common, one of those operations. Okay. And let's talk about the vital signs.
Yes. Patient's blood pressure is 144/72.
Uh-huh.
Temperature is 104.
Uh-huh.
Pulse is 74.
Uh-huh.
Respiratory rate is 18.
Uh-huh.
And saturation is 98%.
98%. So what does that tell us? We know tachycardia, right? So we just have to see the pain, and kind of related, the heart rate goes up, so we need to worry. Okay, what else examination? What is the main thing we just kind of let's go to the abdominal examination. What is in the abdomen?
On abdominal examination, there was a surgical scar which was present.
Yeah.
Bowel sounds are normal.
Uh-huh.
Abdomen was soft.
When you talk about the abdominal examination, first always inspect it, right? You inspect it and say is there any mass or visible peristalsis, right? If there's an abdominal obstruction or visible pulsation, those kind of thing I look at it. Abdominal aortic aneurysm is one of the differential diagnoses. And then what do I do? Inspection. And then I also look at the position of the umbilicus, right? Sometimes the mass or anything kind of that. And then we do what is the other one? Inspection, palpation. Okay, and the percussion and all that. So is there any mass and all those? On inspection, you said there was a scar?
Yes, there was a surgical scar present.
And what about tenderness? So is there what do I need to know? There's a guarding or rigidity, right? That's why there's a guarding or rigidity. The first thing I do is make sure, call surgery to make sure, get a scan really fast and all that. So there was no guarding or rigidity or anything. Okay.
This is generalized abdominal tenderness.
Okay. Did you do OBGYN exam, but she didn't have any? One thing we forgot, you did not tell me about the OBGYN history, right? Is it important in this patient to get the OBGYN history, right? So don't forget that. Okay, how many kids they have, what kind of past medical history, OBGYN diseases you got. We talk about endometriosis and OBGYN malignancy is also very common and all that. Okay, do we need to do a rectal examination on this patient? Probably for the completeness sake, it's also good to have rectal examination. Part of abdominal examination. A lot of people don't want to do it, but you'll be surprised if it is constipation. We already talked about it, right? If there's any of the mass in the rectum or those kind of things, also colonic, those kind of things we need to know, right? It's good to have an examination. Make sure you do very thorough. All right, now let's look at the labs. What labs is important to us?
CBC.
Okay, we definitely need CBC. What else? We'll come back to that. CBC, we need to know WBC, we need to know anemia, there's hemoglobin, platelets also can cause anemia. And then BMP, sodium is important, right? Anytime abdominal pain with the low sodium, dehydration, those kind of things, right? Sodium is also related to malignancy also. Even it's also a marker, it's a, bad prognostic marker also, right? What about potassium?
Yes.
Potassium is also important, right? And then, what is the most important thing in this? Metabolic acidosis, bicarbonate is important, right? Ischemic colitis, any kind of abdominal problem, you have to worry about metabolic acidosis. It could be most of them usually anion gap metabolic acidosis, right? And then you have to worry about BU and creatinine also, right? Is there an obstruction, hydronephrosis, renal stone, those kind of things, renal failure kind of goes up too. All right, so tell me the labs.
Patient's WBC was 13.4.
Uh-huh.
Hemoglobin was 11.4.
Mm-hmm.
Platelets was 174.
Oh, 174 platelets.
Yes.
Okay, so All right. Sodium, potassium.
Sodium was 141.
Uh-huh.
Potassium 3.8.
Uh-huh.
Chloride 107.
Uh-huh.
Bicarb 24.
Uh-huh.
BUN 17.
Mm-hmm.
Creatinine 0.8.
0.8. And what is the blood sugar normal?
Blood sugar was not 89.
89. Okay. What other labs do we need? Anytime somebody with abdominal, what other labs we should check? What I've been telling you all before. Lactic acid. Okay, I would definitely get a serial lactic acid, very important. Did you check a lactic acid?
No, doctor.
Okay, it's important. I would order lactic acid. What else? What other labs do you need? CRP, ESR maybe, right? CRP, ESR. What else? This patient is having some urinary symptoms, right? So what else could be like?
Urine analysis.
Urine analysis definitely needed. UA needed. Was the UA checked?
Yes.
Okay. What did it tell me that you? I mean, was it any urinary tract infection there, or it was normal? It was normal.
It was normal. Yes.
Okay, so it was normal. Okay. Any other lab you should check? Abdominal pain, right? Naturally, calcium can cause us like abdominal pain, but it's not that like we don't have to worry that much about it. Okay. So what is the like? Let's say do some imaging.
Yes.
Okay. What imaging would you do?
Mm-hmm.
Okay, this patient had when we talk about there is, left lower quadrant abdominal pain, previous history of diverticulitis, right? And then he's been having like leukocytosis also. So I'm kind of concerned to get what will be the best. I would definitely get a CT of the abdomen. Okay,
yes.
You can proceed with if you want to do an ultrasound of the abdomen, but a lot of things I think I might consider like an abscess. I could get a very clear picture getting a CT of the abdomen. So what did you do? Did you do a CT at all?
Yes, doctor. We did CT abdomen with contrast.
What does it show?
The impression was we saw acute diverticulitis involving the descending colon.
Diverticulitis.
With pericolic fat stranding and microperforations.
Plus microperforation. Okay. So we got our CT scan finding of diverticulitis. So based on all this kind of thing, right? What's our number one diagnosis? We can say acute diverticulitis, right?
Yes.
Everybody agree?
Yes.
Acute diverticulitis. So what's the first step you have to do? When you your diagnosis right here, we talked about all this thing. We got like WBC count of 13, right? We got diverticulitis and microperforation right here. We got previous history of diverticulitis in this patient, right? So what is so our number one diagnosis acute diverticulitis, what is the first thing we have to do?
We'll give empiric antibiotics and endoscopy.
Okay. Empiric antibiotic. Okay. That is, the question first thing you have to do is is it complicated or uncomplicated?
Okay.
That's what I do. Okay. First thing is is it complicated or uncomplicated? But you said something else. Endoscopy.
Yeah, after antibiotics.
No way.
Okay.
Okay. That is the worst answer you can give. Be careful when you say something like that. What happened is a lot of inflammation and all this hot stuff, and you try to put a scope through that. What's going to happen?
Perforation.
Perforation. Do you want the patient perforated and die on your table when you do endoscopy?
No.
No. Okay. So be careful. Venosus, that's that's one of the worst mistakes you can make. I've seen people doing that in patients have complication, perforation, surgery, peritonitis, and death. So be careful. Okay. So the first thing I do is a complicated or uncomplicated. Is it a complicated or uncomplicated? Somebody tell me here.
Uncomplicated?
Okay. If they're so what is a complicated definition? Somebody tell me what is the definition of complicated diverticulitis? If they're an abscess, okay? If they're an abscess, what else? There's a fistula, right? What else? Perforation. When you call about microperforation, if it is kind of contained microperforation, you cannot complicate, you cannot think it's a complicated, okay? So, I agree. In this patient, I have a little bit of, microperforation, right? So, you probably give some antibiotic. You can probably give a pure antibiotic. And I would start with, let's start with the other thing. I would do bowel rest, okay? bowel rust. And in this condition, I think I'm still calling it an uncomplicated, so I would do like, back trim and then flagell probably. Usually 2 antibiotic I'll combine. Back trim, flagell. How long should we give? 10 days. 7 to 10 days is the current recommended, okay? And did we check the blood cultures? Definitely, why not? Blood cultures. Okay, and then what else we need to do? Okay. Do we need to consult anybody?
No.
No.
Why is that? When do you consult people? We already said this patient had a previous history of diverticulitis, right? If it is the third episode, it's better to consult surgery and thinking about like doing the resection because the recurrence rate is less, okay? And I don't think anything they're going to be, it's only like the second episode. It's not like there's no abscess, there's no perforation. Okay, let's say there is an abscess. When do you call surgery? It was like, let's say this patient came back, diverticulitis and the abscess. Give me a number. What is the number you have to kind of act on it like right away? If it is, number is 3. If it is less than 3, abscess size, you manage conservatively. You can give IV antibiotic, right? So, but if it is greater than 3, then automatically you need to call surgery. You might have put a drain or like surgical option is the option right there. So it's very important to know that. Everybody got it? So let's say if it is a complicated diverticulitis, then I probably put the patient on IV Zosyn, probably a good idea to cover all the organisms kind of mentioned. Okay, and then you said about colonoscopy. When do we need to do colonoscopy? It's not bad answer, but the timing is more important. But definitely this patient needs colonoscopy. When do you do the colonoscopy in this patient? After 6 weeks. You get everything kind of calmed down. Why do we do that? What are we trying to rule out? Malignancy. If the patient have a complicated diverticulitis, the risk of malignancy is around like 7 to 8%. If it is uncomplicated, still 3%, so it's better after 5 to 6 weeks, you make an appointment, or you can consult GI and say like, hey, 6 weeks later, I need a colonoscopy. Okay, so it's very important to know that. So we can follow up this patient and then treat with antibiotic and see how the clinical course is. But it's good to know like how to manage and all that. Any questions? Okay. Remember, like when you have I know this patient have a little bit of urinary symptom, urine analysis normal. But when you have diverticulitis, right, sigmoid diverticulitis is very common. Sometimes you can press against the bladder and then can have urinary symptoms and all that. Okay, don't assume automatically it's a urinary tract infection. Urine analysis was normal in this patient. Okay, all right. Thank you so much for everyone watching. Please put some comments under the comment section. Anything about the management, if any other important point we missed, so we all can learn from each other. Thank you so much for watching again. Please subscribe to our channel. It will be extremely helpful because again, all of this efforts taken by so many people's hard work. Okay, thank you again.